Okay, so this presentation will cover prenatal and antepartum nursing care, and we kind of go back to the beginning. And under normal circumstances, I would not cover material like this because you need all that postpartum care and intrapartum care in order to be able to apply it in clinical. So there was a method to my madness in terms of presenting the material kind of out of order like this. So this goes back to the beginning, but this is the part that we didn't see as much in clinical. So that's why this comes at the end and not at the beginning. We are going to start from the very beginning with the menstrual cycle. Then we cover fetal development and also prenatal testing, antepartum testing, and education. So that's what this presentation will cover. And again, this information will not be tested on exam 3. It will be tested on your final only. So the menstrual cycle average is 28 days. That is not, that's just an average. Normal is considered between 20 to 45 days. And that comes into play when we talk about conception, because if couples are trying to conceive, you can't rely on, your cycle to be 100% textbook every month. So when we talk about a discrepancy of 20 to 45 days, you're really talking about a discrepancy as well in terms of when do you ovulate, because when you menstruate is related to when you ovulate. And when we're trying to pinpoint the time frame in which we could attempt to conceive, we want to know about the time that you would ovulate and release an egg so that your chances are a little bit higher of conceiving. So we're going to cover the reproductive cycle, the female reproductive cycle, and it's probably going to take you back to A and P, but the important piece of why we cover this and why we need to talk about it is related to education. Nurses do a lot of education in the office. So this is really a lot of a review, but our piece of it is going to be how do we apply it in a nursing setting where you're providing education to patients related to this cycle. So here I've broken there's two different phases cycles that are going on. There's the ovarian cycle, which is the pink side of things over here on the right. And then there's the endometrial cycle, which is the black side over here on the left. And the phases of these coincide, okay? So they're happening simultaneously. The ovarian cycle is what's going on in the ovary and everything that has to do with egg development. And then the endometrial cycle is what's going on in the lining of the uterus. So we will start, and this is kind of a nice visual, I said, to kind of bring the two cycles together. It's going to make more sense as you hear the different characteristics of each phase, and then there's an image after as well that hopefully will help pull it together. But I would refer back to this slide after I've covered each of the phases of the endometrial and ovarian cycles so that you can kind of see how they mesh together and why they work the way that they do. So it's pretty awesome. I think it's kind of magical. So I think about that about a lot of things in this subject matter. So, all right. The ovarian cycle is where we're going to start. So the follicular phase, I give you what days that the follicular phase are typically happening in a normal cycle. And then for each phase, I also give you what hormone is driving that phase of the reproductive cycle. So the follicular phase is driven by FSH, or follicle stimulating hormone, and luteinizing hormone. And these two are focusing on growing an egg. Okay, so day 1 through day 14, we are growing eggs, okay? And multiple eggs are grown, but only one is released and matures enough to be released into the fallopian tube. The ovulatory phase, there's a spike in FSH, LH, and we also add in some estrogen. And this is when an ovum is released from the ovary. And it's typically around day 14 of a regular 28-day cycle. And this is important to know in terms of education. There's a slight drop in the mom's temperature 1 day prior to ovulation. And then there's a slight increase in mom's temperature consistently post-ovulation. So for people who are trying to track when they're going to ovulate, if they take their temperature at the same time every day, and they can kind of notice a trend down in their temp, they know that they may be ovulating at that time, and then an increase afterward kind of gives you a good indication that you have already ovulated. So for people trying to track that, that's an important fact, and it might be something you want to circle star smiley. Spin-Bear-Keat is also another indication that ovulation is occurring. It's a cervical mucus change that is indicative of an egg being released. So what happens is the cervical mucus becomes elastic and kind of slimy during ovulation. It's a good medium for sperm to travel through. So this cervical mucus is a good environment for sperm and actually facilitates movement of sperm into the cervix through the uterus and then to fertilize the egg. The consistency is about like the egg white of a raw egg. So that's kind of what the consistency would be and what you should instruct your patients to look for. Middle smirts is pain with ovulation. So these are fun words to say, but pain with ovulation, many women will complain of a pain mid-cycle. It's usually on one side or the other, and it's often very common for you to experience pain on the opposite side from the side that you're ovulating. So if you're ovulating from the right side this month, some people will complain of pain on the left side. It's like referred or something. So that's not uncommon, and some people will have some severe middle smirts, and some people do not know that they're ovulating at all. So in terms of that pain, they won't have that pain at all. So those are very important pieces to remember in terms of education for your patient to look out for signs for ovulation. After ovulation occurs, the luteal phase takes place, and so that's the second half of the ovarian cycle, and hormone secretion depends on whether or not that egg was fertilized or that ovum was fertilized into an egg. Something called the corpus luteum is present in the ovary. And the corpus luteum is actually the sac that the ovum was released from, okay? So if this egg, or if this is, if the ovum is released, the corpus luteum begins to secrete estrogen and progesterone to build the lining of for pregnancy. So regardless if it's fertilized or not, that corpus luteum is going to start to build up the lining of the uterus, okay? Now, if the ovum is fertilized, then we also, in addition to that estrogen and progesterone to build up the endometrial lining, we submit human chorionic gonadotropin hormone, which is HCG, which is our pregnancy hormone and is what is detected in a home pregnancy test. If implantation does occur, estrogen and does not occur, the estrogen and progesterone drop, and that sudden drop in estrogen and progesterone is what causes menstruation to occur. So again, remember the term corpus luteum because that is that little sac that kind of keeps pregnancy going and secretes estrogen and progesterone to keep the lining of that uterus ready for pregnancy and ready for implantation if that ovum becomes fertilized by a sperm. Okay. So now on the flip side of things, the endometrial cycle, it's hard to kind of start from the beginning. I wanted you to see how they coincide with the different phases of the ovarian cycle. So I started with the proliferative phase because that's day 5 to 14. And that is when that, it's around when ovulation. So just before ovulation is happening, estrogen is building up, and it's development and preparation of that endometrial lining for implantation. So when that egg is released, if it's fertilized, you've got a very thick endometrial lining for implantation of the egg. And then the secretory phase is the day after ovulation through 3 days prior to the next menstrual cycle. Progesterone and estrogen are going to be high. They're coming from that corpus luteum, because that corpus luteum knows that the egg is released and it needs to prepare the lining of the uterus. This is when the maximum endometrial thickness is achieved, and it secretes, that endometrial lining secretes nutrients for the fertilized ovum if it is present. The ischemic phase occurs about 3 days prior to menstruation, and this is if the ovum is not fertilized. You have that decrease in progesterone and estrogen because there's no egg to support, and blood supply to the endometrium is blocked, and it helps that lining die. Okay, so essentially necrosis occurs, and in that 3-day period of necrosis, it transitions over to the menstrual phase, and that's when you have your menstrual cycle, day 1 through day 7, typically, and it's a shedding of that necrotic endometrial lining. But remember, during that menstrual phase, day 1 through day 7, is when you're having your follicular phase. So you're growing another egg as you are shedding the lining from the previous cycle that was not needed for a pregnancy. So pretty amazing. And I, again, encourage you to go back to kind of see how they enmesh together. And that day 14 is ovulation, and it marks usually the middle of a cycle. Here's a nice image of what's going on. So I think it's really, I think looking at this really helped me when I was learning this, to see how they kind of coincide. And, obviously we're releasing our hormones from our hypothalamus, the FSH, the LH, and so you can see how the levels of each of those, spike and rise prior to ovulation, and how during your menstrual phase is when you're starting your follicular phase of growing that ovum to be released, and then you have a increase in your estrogen to grow that proliferative phase of your endometrial lining. You ovulate, and then in the secretory phase, you have that increase of progesterone and estrogen that help to even further grow that endometrial lining. The luteal phase is where that corpus luteum is still present and feeding that endometrial lining. And then the ischemic phase hits if we do not have a fertilized ovum, and progesterone and estrogen drastically drop, and then you have your menstrual phase again. So I do think this helps kind of bring it all together, this slide, and in addition to that other slide that I showed you initially. So pretty cool. All that's going on while we're just kind of living our lives. So kind of amazing. All right, so conception. So we're going to talk about fertilization. Again, we've talked about a little bit about this in terms of ectopic pregnancy. Fertilization is meant to occur in the fallopian tube, and then the zygote moves down the fallopian tube and should implant into the uterus. It takes about 3 or 4 days for it to enter the uterus. In ectopic pregnancy, as we know, it does not make it to the uterus. It implants in the fallopian tube, which is not a good thing to happen. It requires patent fallopian tubes, an adequate sperm count, amount, and the number and their motility needs to be improved, and not improved, but adequate in order to fertilize the ovum that was released. Implantation is usually completed in 7 to 10 days. So that's, and when you think about it, if you think about the cycle, there is some bleeding that occurs with implantation. And if you think about the menstrual cycle, the timing of that implantation is right around the timing that you may have your period. So a lot of people confuse that implantation bleeding with their period, and that's how you wind up on, I didn't know I was pregnant. So that is sometimes a little bit shocking to people, that it can be enough blood to mimic a cycle, but it happens more often than you might think. So this where it implants is important. Up in the upper part of the uterus is the best. It's where the endometrium is the thickest, and it prevents deep attachment. So it prevents the occurrence of a placenta accreta, which we covered. Increta or paracreta, so any of them. And it also correlates with prevention of placenta previa. So higher up in the uterus is best. And it also helps with prevention of postpartum hemorrhage. Obviously, we can't really prevent this. It's going to implant where it's going to implant. We can't really control that. But if we know that it is implanted in the upper part of the uterus, it is a better outcome. And if we know that it's lower, we can obviously prepare for difficulties. So if it's implanted high in the uterus, that is also where after delivery, once the placenta is gone, the greatest amount of clamping down or contraction of the uterus is going to occur. So you're less likely to have a postpartum hemorrhage if you have a placenta that's higher in the uterus. This correlates with lower blood loss after delivery, which is what I just said. Yep. So it's really important also to remember that the cells at this point, the zygote, is not susceptible to teratogens at this time. And the reason for that, so when we think about, people, have a few too many and then they get pregnant, you worry, was I drunk when I conceived and all of that? And it doesn't really matter. Okay. There's no blood supply to that baby from maternal blood supply. The placenta hasn't even developed yet. So there's not really a risk. It's not probably the best thing to do because it's probably not 100% planned, but it's you don't have to be worried if that is how you conceive, or if you were conceived that way, what the outcome of that. So I guess good news. Assessment and care. So preconception and interconception. So it is always best to catch women prior to pregnancy, or, while they are trying to conceive, to be able to identify problems. This is the best time. Obviously, that doesn't happen for many pregnancies. Not all pregnancies are planned, but it's a time that you can identify problems and risk factors for mom, and risk factors for mom during pregnancy. We provide a lot of education. We will do a screening prior that includes a full history. We do vitals and a head to toe physical exam. We will do screening for rubella, Hep B, and varicella. So if they need to be vaccinated prior to conceiving, we will do that because, as we know, we cannot receive rubella or varicella in pregnancy, and they need to be vaccinated afterwards if they do come in and they've already conceived. We review their medications and any medications that may affect a pregnancy. In terms of a lot of psychiatric medications, we need to evaluate in order to make sure that the pregnancy is safe during that time. And of course, it's always like a delicate balance between what mom needs and what baby needs. So if mom is not going to be healthy off of her medication, and it presents a greater risk to the pregnancy than if mom were to be on the medications with potential side effects, then we have to weigh those risks and benefits. And decide whether or not to have mom continue with the medication or not. So that is, and different medications have different classes for risks and side effects to the baby. I don't ask you to remember any of that, but we do have a big old book in our nursery at Saratoga that covers medications in pregnancy and for breastfeeding, and we refer to that very, very often. So that's not something that I would expect you to memorize. Why would you? There's a big old book on it. So nutrition. Preconception, it's really good to have them increase their folic acid. If they already get pregnant, we want to increase their folic acid as soon as they know they're pregnant, but preconception is always best. So 400 to 800 milligrams for a month prior to pregnancy, and then through 3 months gestation. After 3 months, we decrease them to about 600 milligrams. So basically, they should be just taking a prenatal prior to getting pregnant. If you're trying to conceive, you should be taking a prenatal. If the mom has a history of a child with a neural tube defect, we would prescribe up to 4,000 milligrams to prevent neural tube defects from occurring in this current pregnancy. So folic acid is a big one. Confirmation of pregnancy. All right, so you've had your preconception counseling, you know that, you've started your prenatals, and now you think you're pregnant. And we have to go through the presumptive, probable, and positive indicators. I would circle, star, smiley all of these and know the difference between each. We don't talk about confirmation of pregnancy like this in the hospital. This is something that I see in the HESI review as being something that is important for your NCLEX. But in terms of, confirmation of pregnancy, it's much more simple in the United States, in our area, than what is presented here to confirm pregnancy. And some of it actually is a little bit silly. So I will go through it. You need to know it for, in terms of NCLEX, and that's why I cover it kind of heavily. But in practice, the positive indicators are so easily achieved and readily available. Access to care is pretty decent in our area. So we don't even worry about really the presumptive or probables. We skip right to the positives. All right. So these are just determining, are you pregnant or not? So presumptive indicators, and you're going to see why I think this is kind of silly here when we start talking. So the least presumptive indicators are the least reliable indicators of pregnancy, and it's because there are common signs and symptoms of other types of conditions. So amenorrhea is a word you should know. So missing a period, not having a period, is an indication that you could be pregnant. Nausea and vomiting, fatigue, urinary frequency, and urinary frequency is usually a common symptom of pregnancy in the beginning, and it's usually related to increases in hormones. Breast and skin changes. Breasts can become tender. There's a darkening of the areola often. There's something called a mask of pregnancy where it almost looks like raccoon eyes. So right around the eyes, they will have kind of a darkening, and that can be an indication, but usually that's a little bit later in pregnancy. So if you've kind of missed the boat, then I guess you can rely on the mask of pregnancy or melasthenia to tell you that you're pregnant, but I wouldn't. Linea nigra, again, it's a darkening pigmentation. It's usually in darker skin cultures, and it is a line from the pubic bone up to the belly button, and sometimes it extends above the belly button as well, but it's just a darkened pigmentation area in the skin of the abdomen, and that is a presumptive indicator. So, and again, I feel like I see that's later in pregnancy. So if you've really missed the boat and you're on, I didn't know I was pregnant, then I guess that you could use that as an indication that you're pregnant. But again, there are better ways. Fetal movement. So if you start to feel a baby move inside of you, which, that's a little harder to distinguish than you might think. Sometimes people think they have a baby in there and it's just gas. But again, it's kind of silly to think that you would wait until you felt fetal movement to decide that you were pregnant, or to confirm that you were pregnant. Vaginal and cervical color changes. These are important to know. So star, circle, smiley. Chadwick sign is a blue hue to the cervix, vagina, and labia. In pregnancy, there is an increased vascularity in those areas. So there's a lot more blood in those areas. And that's what gives it kind of a blue hue. So that is a presumptive indicator that you are pregnant. Again, all of these are very, low reliability. You should move on to other ways of confirming your pregnancy if you are using these. Probable indicators, so you're probably pregnant, okay? So if you have abdominal enlargement, however, it could be the cheeseburgers. Again, we need to make sure that we confirm our pregnancy in a little bit more thorough way. Cervical softening, please circle star smiley that. You need to know the definition of Goodell's sign, and that is a softening of the cervix. So that would have to be palpated by yourself or a physician to see if you had a softening of the cervix. Changes in uterine consistency. So obviously a pregnant uterus is different than an unpregnant uterus, and that you can probably palpate a pregnant uterus a little bit easier. Ballottement, that is a very, very late sign. If you have a physician do a cervical exam on a patient and they have ballottement means that when you put your fingers in there, it's kind of a rebound effect. Like the baby's head, you can feel like a head floating, like a balloon. The uterus is like a balloon, and then the head is kind of floating in there. That's what ballottement means. So if you are feeling that, you are very pregnant. Braxton Hicks contractions. So if you have contractions, you're probably pregnant. If you can palpate the fetal outline, probably pregnant. Again, a little bit silly. Pregnancy tests are a probable indicator. I actually think these are kind of more of on the serious side of things. Like I think I would take that at face value. But there is a chance for false positives. There's more of a chance for false negatives. But when we test at home, we are testing for that HCG or human chorionic gonadotropin. And when we provide education to patients on how to conduct these tests, we tell them to use their first morning void, because that's going to be the highest concentration of HCG. So you're more likely not to test, have like a false negative reading because of a low level. But these pick up HCG at a very, very low level. I think it has to be like 5 in order to pick up. Your level has to be like 5, which is very, very low. Instruct them also to not test for pregnancy until 1 week after their missed period. So we have all of these tests now that actually claim that they can pick up on pregnancies a week prior to your missed period. Okay, there are cases, yes, that is 100% true. However, if you are testing positive prior to your missed period, a lot of pregnancies are lost in that time frame. So there's a higher occurrence of people who are testing positive and then they get their period and it was actually, something went wrong in the pregnancy and tends to be kind of a miscarriage. So even though we instruct them not to test till a week after their missed period, I do think we miss a lot of pregnancies. Like people are pregnant, but they don't know it. Like when periods are a little bit late, maybe not, right on time, but you're not like super worried about it. I think that those are potentially where, you may have, had kind of a false alarm where you could have had some fertilization and it didn't implant, but it was enough to produce a little bit of HCG, and you could have a positive pregnancy test. So that's why we tell people not to test until 1 week after, because it's kind of like get your hopes up and then it doesn't happen. Very important that we provide education on testing for pregnancy at home. And again, pregnancy tests at home are a probable indicator. Positive indicators of pregnancy are what we see the most, okay? And that is what we will, and typically it works like this. You have a probable indicator of a positive home pregnancy test. Then we bring you in and use our positive indicators to, confirm the pregnancy. So auscultation of a fetal heart rate, visualization of the embryo or fetus on an ultrasound are the two positive indicators that you need to commit to memory. If you have fetal movements felt by an examiner, you've got a pretty large child in there. And again, I think you've probably missed the boat. So I guess some of these are in here because they apply to other countries or other locations where maybe access to care is limited and we don't catch pregnancies very far in, ahead of the game. So it's really important that you realize that in where we are located and in our area, we just bring people in and listen for a heart rate, usually around 6 weeks. That's when you start to hear it. Visualization of the embryo or fetus on the ultrasound will confirm that pregnancy, and that kind of just, wraps up all of those other presumptive and probable indicators altogether. So pregnancy length, we've talked about this immensely, but we're going to talk a little bit more in depth. We count from the first day of the last menstrual period to 40 weeks, right? So 40 weeks is a full-term pregnancy. We divide our pregnancy into 13-week trimesters. So the first trimester is the first day of your LMP until you're 14 weeks pregnant. Second trimester is 14 weeks until 27 weeks. And your third trimester is 27 weeks until 40 weeks. And when I am presenting the remainder of this material, it will talk about the development of the fetus, what mom's experiencing during these trimesters, what education, what's their social status during each of these trimesters, and what screenings fall during these time frames. So that's how this PowerPoint is organized. When we calculate their due date, this is something that you really need to know. It's highlighted for a reason. Nagel's rule, we will take their last menstrual period date. You count back 3 months and add 7 days. Okay, so that's the old school way to do it. We also have an EDD wheel, which it's just a circle wheel that you can calculate their due date from, and I'll show you that to you guys in the collaborate session. I'll kind of show you what one of those looks like. They're very easy to use, and now in modern day, right now, we just punch it into the computer, and many of the documentation systems for OB will just calculate the estimated date of delivery. So an example of Nagel's rule would be, suppose your last menstrual period was March 23rd. The estimated date you would count back, so February, January, December 23rd, and then add 7 days, 23, 24, 25, 26, 27, 28, 29, 30. So December 30th would be of the next year, 9 months from March would be the due date. So that is something you should know how to do. There will definitely be questions on how to do that and how to apply it. But just to let you know, I won't ever put it so that you have to, when you count 7 days, it'll go into a new month, because that would require everyone to know how many days are in each month. And I don't think everyone including me, always knows that without singing the little poem. So I won't do that. It'll be 7 days tacked on to the same, and stay within the same month. Embryonic period. So we're starting, we've conceived, we've confirmed our pregnancy, and we've calculated a due date. And we're going to talk about what is going on in terms of that baby in weeks 3 through 8. So embryonic period is what this is. That's the embryonic stage. All basic structures of all major body organs are completed by week 8, and they function at a basic level. So that's really impressive that you've got kind of a complete human in those 8 weeks. That all the pieces and parts are there, and they just have to mature in an 8-week time frame is amazing. And it's also important to think about that in terms of early, the changes early on in pregnancy related to the baby are much more, from day to day, there's vast changes in that baby, as opposed to a 35-weeker versus a 36-weeker. Yes, they have better lung development and all of that, but their actual physical features are not as abrupt from day to day. Most susceptible to teratogens during this time. So remember how we said conception, you don't really have to worry about teratogens. There's not a good blood supply. This period of time, week 3 through 8, is when the fetus is most susceptible to teratogens or outside chemicals and factors affecting its development and potentially causing congenital anomalies. So susceptible to drugs, viruses, radiation, infection. So it's really important to be very careful during these weeks. 8 weeks, so we hit that 8-week mark, and the fetal heart rate should be present. The heartbeat would be present. Typically, it's found as early as 6 weeks. Facial features are identifiable, so you can see it has an eyes, a nose, and a mouth. There are limb buds. They're not fully developed limbs, but there are buds there where limbs are going to form. Maternal signs and symptoms, this is when they're potentially going to have that nausea and vomiting. This usually persists up through 12 weeks, potentially getting better in the second trimester after 14 weeks, but not always. Sometimes people are just pukers and they have nausea and vomiting throughout their whole pregnancy. Urinary frequency usually is caused by hormones. Also, they have they're building up their blood volume, so they can also have some urinary frequency related to that early in pregnancy. Goodell sign is what we covered before, and that is your softening of the cervix. Noticeable change in weight gain, there is no noticeable change in weight yet. Okay, so the baby's too little to be starting to put on weight. Anything you put on is typically water weight at that point. Chadwick's sign is the blue hue to the labia, cervix, and vaginal wall. There could be some breast tenderness, darkening of the areola. And this is early in pregnancy, we're already starting to develop breasts to be prepared to breastfeed. So estrogen and progesterone that are present to maintain the pregnancy also are responsible for preparing breasts for breastfeeding moms after delivery. So it's really important, these levels of estrogen and progesterone, if they're not adequate, one, they may not maintain the pregnancy, and two, they may not, you can have effects from this in terms of breastfeeding after delivery. So, it's even this early on, breastfeeding is starting to, the foundation for breastfeeding is starting to be developed. The estrogen is responsible for the growth of the mammary ductal tissue, and progesterone is responsible for the growth of the lobes, lobules, and alveoli. Our psychological response, mom's psychological response during the first trimester, very, very common for moms to be uncertain. Okay, they go through kind of a little bit of spell of like, no matter how they're uncertain, they're seeking confirmation. Am I really pregnant? I have a positive pregnancy test, but is it really true? Ambivalence, it's very normal to be like, oh my gosh, what did I do? Even if you did plan the pregnancy, you have a little bit of a conflicted feeling. And early on, there's this center on yourself. You don't have really good proof that there's something in there growing. You can't feel it. You're not large at this point. So you're still kind of focused on you. And you're kind of thinking about, oh, what am I going to do about my career? Are there issues financially? I'm going to have an increase responsibility coming my way. So all of these are very normal feelings to have. And as nurses, we're just there to support and listen to them and just explain to them that it is a normal feeling to be uncertain and ambivalent and really concerned about yourself during that time, and how it's going to affect your life. And they usually move past it. But again, we're just there as support for that. And we don't really usually do anything but listen and encourage. changes in sexuality. So usually during this first trimester, moms their libido is very low. They don't feel good. They're puking all the time. They're exhausted. So after conception happens, typically sex drive drops way down in that first trimester. Okay, so after that initial preconception appointment and then confirming pregnancy, we are talking about our first prenatal visit. So this is typically between 6 and 10 weeks. This is where that confirmation of pregnancy takes place. It's a very long appointment. It's about 2 hours. To kind of get all the education in, do lab work and ultrasound and screenings. And it's really an opportunity to start to establish trust, kind of get a feel for the family and what their expectations are for the management of their pregnancy and their delivery. We're going to, again, verify or rule out the pregnancy. So we do that first trimester ultrasound, education before they come in for that ultrasound, make sure that they have a full bladder for the abdominal portion, because the uterus is not big enough yet for it to be visible from the abdomen view. So we have to make sure that they have a full bladder, because it pushes that uterus up and out into the abdominal cavity a little bit better, so that we can view that on imaging. Usually after the abdominal portion of the ultrasound, and when they switch over to do the transvaginal portion, they will have them void first. Obviously that would be very uncomfortable with a full bladder. So in addition to that, we are establishing the presence of a fetal heart rate. So that's between 6 and 7 weeks that we should start to see that. Fetal heartbeat movement on ultrasound, the number of fetuses that are present, and what is their gestational age. So most of the time we can use their last menstrual period. However, some people do not have regular cycles, and some people do not know when they last had a period. So we can use ultrasound in early pregnancy, so this first trimester, to really pinpoint when this baby was conceived, and then also when they would be due. So the reason why an early ultrasound is more accurate in identifying gestational age is because, remember, that baby's day-to-day change is so significant in the first weeks of pregnancy. So measurements and characteristics are very different from day to day, as opposed to a late in pregnancy ultrasound. It's a little hard to tell, a 6-month baby from a 7th-month baby, or a 7-month baby from an 8-month baby. So that is really important to remember. And then also we're negotiating a plan of care. Like, again, what are your expectations for pregnancy and delivery? And can we meet your needs? People are really shopping around for doctors. So sometimes you have this first initial visit and they're like, I didn't really have a great experience, and they will transfer their care elsewhere. So we are prepared for that as well. What is involved in the medical history is just a big long list. We really focus on the obstetrical side of things, the gynecological side of things, as like more of a focused history. So, and we take everything into account. So their contraceptive history, their menstrual history, surgical history, family history, anything with their partner's health history that would come into play, and of course a psychosocial history. I don't go into detail about all of these, but as you can imagine, anything that is in this patient's history is going to potentially impact the pregnancy. So we would want to do a thorough patient interview to gather all of this data. So again, the focus is on this obstetric history. We talk about gravida and para, so how many times have they been pregnant, how many delivers have they had over 20 weeks, what were the length of their previous gestations, the weight of the infant's birth at delivery, previous labor experience, so did they have anesthesia, and what is their expectation for a future delivery, any maternal complications that they may have had, any infant complications that arose in pregnancy. We also want to know how they fed their baby in previous pregnancies or after previous pregnancies, and what their desired infant feeding method will be for this pregnancy. If they bottle fed the first baby, it doesn't mean we don't provide information on breastfeeding. We still, there's a lot of moms who kind of flip-flop back and forth. Some of them breastfeed initially, and then they end up bottle feeding a second child. So it varies from patient to patient, but we just want to know their plans so we can provide appropriate education and care. Again, determining that estimated date of delivery, so we can use Nagel's rule if they have a really solid LMP date, or we can use and then use that LMP date and then confirm the gestational age with ultrasound. That's really the most accurate way. Vital signs are going to be taken. We do a head-to-toe physical exam. We're going to obtain baseline lab values. We want to know their baseline hemoglobin and hematocrit, their blood type and RH in the event that they would need RhoGAM later on in the pregnancy, urinalysis, white blood cell count, Pap smear and cytology, and we will test for gonorrhea and chlamydia at this point. Remember, those two are a torch infection, so we would want to treat as quickly as possible. Antibody screens would be for HIV, Hep B, toxoplasmosis, rubella, syphilis, and cytomegalovirus. So those we want to make sure that they have a good titer and are immune. Additional early screenings that we can do, amniocentesis and chorionic villi sampling. You don't have to know too much about these, just that they are typically used in early screenings for people who are at risk for a lot of genetic anomalies. So there are people who get preconception screening for potential genetic anomalies. So they would take genetic material from mom and dad and kind of see if combined, could it develop an issue? And that is usually done for families who have a known genetic trait that it may be undesirable to pass on. In terms of disease, I'm not saying like dad has a big nose. I don't know. I just don't want you to think they do it for anything but like a medical indication. Amniocentesis is an amniotic fluid sample under ultrasound guidance, and they will take a sample of the amniotic fluid, test it for genetic material. This is done around 12 to 13 weeks. It can be done later in pregnancy to assess fetal lung maturity and fetal well-being. So there are times that they will do an amniocentesis to see if delivery is necessary or when delivery is necessary, and they're concerned about the fetal lung maturity of that baby prior to inducing or C-sectioning the patient. So primarily it's done as a genetic diagnosis, but it also can be done later in pregnancy as well. And then chronic villi sampling is a sample of the fetal side of the placenta, again done under ultrasound guidance, and they do this around 8 to 12 weeks, and this is for more specific genetic diagnoses as well. After the 8 weeks, we enter from the fetal period, which is 9 weeks to 38 weeks. So this is a pretty big span of time. And this is when you don't have to worry as much about genetic anomalies anomalies being caused by teratogens or outside problems, drugs, alcohol, any kind of exposure to viruses. We wouldn't have to worry as much. We're still concerned and we're still very careful, but the most intricate development happens during that embryonic period, and is very, most people say to be safe after the first trimester, so up to 14 weeks. You really want to be careful. The schedule for visits after that initial pregnancy confirmation appointment that we just talked about is conception to 28 weeks is every month. So once a month or every 4 weeks, you would see your doctor and get screened. We'll talk about what they do in these subsequent visits upcoming in the presentation. 29 to 36 weeks, we go to every 2-week appointments, and then 37 weeks to birth, we go weekly. So obviously the closer to delivery, the higher the risk of we want to watch them more closely as they get closer to delivery. What happens at those subsequent visits? Every single one, you're going to have vital signs, a weight check, a urine dip. We're going to check for protein every time you come in, just in case you're developing preeclampsia. We do a fundal height. We're going to empty the bladder prior to measuring a fundal height, and a fundal height is a really good way to know whether or not you need to do further investigation. So the fundal height is measured from the pubic bone to the top of the fundus of the uterus while mom is pregnant. So from 20 weeks to 32 weeks, the height in centimeters of the measurement from the pubic bone to the top of the fundus should be equal to the gestational age of the fetus. So if you have a 22-week fetus, you should have a 22 centimeter fundal height. If you have a measurement that is less than the gestational age, that would indicate that maybe you're having a baby that's not growing adequately. And if you have a fundal height that is greater than the gestational age during that time frame, you might be a little bit concerned that you have a baby that's a little bit on the big side. So during that time frame, it makes it easy to say, oh, maybe we need to look at this kiddo on ultrasound to get a little bit better of a view. Every appointment they'll do Leopold's, and that's just a method of determining the position of baby. They just put their hands on mom's belly. They're feeling for the fetal side. They're feeling for meaning the fetal part side, so where the arms, the legs are, where's the butt and the head, and then where's the fetal back. It just helps to kind of give us an idea. Primarily, we're doing it to make sure that the baby is cephalic presentation or head down. We'll do a fetal heart rate, normal fetal heart rate. Usually they're a little higher in the beginning of pregnancy. On the higher side, 150s, 160s. As the pregnancy goes on, they tend to drop down into that 110 to 160 range. Review signs and symptoms of labor at every single visit, because one of the ways of preventing preterm labor is being able to identify it. So helping to provide education so that they know to come in or call when they're having those signs and symptoms is crucial. In the second and third trimester, we usually do an ultrasound. Now, not every insurance company covers a third trimester ultrasound without a indication, but I will tell you that a lot of physicians will try to find an indication to do a third trimester ultrasound. You always get the second trimester ultrasound. That's typically done around 20 weeks. It should also be a full bladder, just like your first trimester ultrasound. And this is where they do the anatomy scan. So this is quite a long ultrasound, and babies really have to be cooperative and minimal movement in order to do this. So they measure the baby's parts head to toe. They make sure everything is present. Kidneys, heart looks good, lungs look good, the brain measurements, everything. So it's, they take a lot of measurements, just make sure all 10 fingers, all 10 toes. This is where they typically can tell you the sex of the baby. Now with blood work, and some people will do genetic screenings, early in the pregnancy, which is a blood test. They can tell the baby sooner than 20 weeks. Usually the earliest is 16 weeks, but usually they don't schedule this ultrasound until 20 weeks. So Now you can just go to Baby Bumps down south in Albany, and they can do an ultrasound for $100 at 16 weeks, and you can find out the sex of your baby a whole month early. So that is something that people do because they can't wait until that 20-week ultrasound. And then amniotic fluid volume, they check just to make sure the fluid levels are appropriate. Glucose screening is done at 16 weeks and 24 weeks if the mom is obese prior to pregnancy, and then 24 to 28 weeks if there are no risk factors like obesity. So just once for those people who don't have that risk factor. We also will conduct a maternal serum alpha fetal protein, which if you remember from previously in this slide, alpha fetal protein is what we detect for neural tube defects in the baby. So typically around 16 to 18 weeks, we will do a maternal serum alpha fetal protein, and that will help point us to know whether a neural tube defect is present. It can be elevated in people who are having twins, so that we would take that into account. And then also just an add-in that lower levels of MSAFP are associated with Down syndrome. So that's what we primarily use the test for, neural tube defects and detection of Down syndrome. We're also going to monitor for fetal activity. So starting in the 3rd trimester, mom's going to do fetal kick counts. We want 10 kicks per hour, and that's considered normal. So if we have a mom who's like, I haven't felt the baby move, we tell them to lay down, have a big glass of water, and just kind of count for how many times they feel the baby move. If it's below 10, then we usually have them come in. But most of the time when we have them do that, they realize that the baby really is moving, but their lives are kind of busy and they may not have been realizing it. So also we want to provide them with RhoGAM at 28 weeks if they are Rh negative. We don't start to do pelvic exams until about 36 weeks. And even then, it's not like a must. If they're not showing signs of labor, then there's no reason to really check them. There are moms who want to be checked because, of course, you know, if you're a multip, sometimes you'll start out kind of at 2 because your cervix is starting to dilate slowly without you even knowing it. So I think it's just peace of mind, like, oh, I'm not starting at 0. At least I'm 2 centimeters before I even kick into labor. I only have 8 centimeters to go as opposed to 10. So I don't think it's really necessary to check people prior to having signs and symptoms of labor. GBS screen, or the other reason you would check them is if there was a medical indication to induce them, and then you want a Bishop score. So that would be a reason to do a pelvic exam if they weren't showing signs of labor. Their GBS screen, where they screen for the group beta strep, and it's a rectal and vaginal swab. It's done between 36 and 38 weeks, depending on what time their appointment falls within that gestational age. Because at that point they're up to 36 weeks or every 2 weeks, 36 to 38 they're doing that every week. So we'll do the GBS screen and see if they will require antibiotics in labor. Towards the end of pregnancy, we will start, especially when they get to those every week appointments, we start to do NSTs when they come in. Where we will put mom on the monitor and make sure that baby looks good. We do a fetal heart rate tracing for 20 to 30 minutes, and it's considered to be reactive, or, basically normal, if there are 2 accelerations with moderate variability within that time frame. So 15 seconds by 15 seconds for an accel is what we're looking for, which you guys already know. If they fail, so if they don't get that reactive strip in 20 to 30 minutes, they don't have accels, the variability is not very good, then they have to do something called a biophysical profile. So a biophysical profile is, it looks at 5 different areas: fetal breathing, body movement, fetal tone, a reactive NST, amniotic fluid volume. So the NST is actually 2 points as part of the NS, the NST that was already done. So if they fail that part, they already have lost points in that category, moving to the biophysical profile. If each category is 2 points, a 6 is equivocal, so that might indicate that delivery is needed. 8 is associated with normal fetal oxygenation. So that's what you're looking for. You want 8 or above, which would indicate that the baby is doing fine internally, and we do not have any, grounds in terms of the fetus for delivering sooner than when they go into labor. However, there may be maternal indications. So now that we've talked about all the different screenings from, and during the fetal period, we're going to talk about the development, not week by week, because that would be crazy, but when things start to kind of change. So at 12 weeks, what's going on with that baby? You have the lower body developing. You're able to determine the sex by blood test, primarily. Usually a 12-week ultrasound isn't even done, so they wouldn't even be looking for sex organs at that time. Kidneys produce urine at this point. Maternal changes, the uterus rises above the pelvic brim, so that uterus is starting to get big enough to be out of the pelvis. You may start to feel Braxton Hicks this early. If you are, you need to drink more. The placenta is fully functional at this point, and at 12 weeks is when that corpus luteum officially dies off, which makes sense because remember that corpus luteum was providing progesterone and estrogen to support the pregnancy. Once the placenta is fully formed, then the placenta provides the progesterone and estrogen to support the pregnancy. So isn't that great how that works? And then also round ligament pain can start to be a problem because round ligament pain, all the ligaments in the body are looser. Due to a hormone called relaxin, and it can cause significant, it's like a Charlie horse, and those round ligaments are located like kind of in the groin area, and it's kind of the support system for the growing uterus. So that could be a pretty significant, like a Charlie horse feeling kind of in your groin. It's kind of awful. 16 weeks, that baby, their scalp hair present, meconium is present in the bowel, bone and muscle start to develop. Mom will start to feel quickening, which is 16 to 20 weeks. Up to 20 weeks, up to 22 weeks is normal. So we wouldn't be concerned if we didn't feel that quickening. And quickening, just so you know, I didn't say this, is the baby moving. So moms should start to feel their baby moving by 22 weeks. Usually, multipares feel their babies closer to the 16-week side of things, and primips, usually it takes them a little longer to feel their baby move, so up to 22 weeks. At 16 weeks, you can start to be producing colostrum, which is a good sign that breastfeeding may go well or that you're going to be able to produce enough. Insulin resistance can happen. So if we think about that transition into later pregnancy where moms become hyperglycemic, there you go. There's the turning point. Weight gain of 1 pound per week beginning in the second trimester is normal. At 20 weeks, so this is about when we're going to be doing that anatomy scan ultrasound, that second trimester ultrasound. Vernix is present. There's lanugo, or hair present on the baby's body. Activities that are going on with that baby. They are sleeping. They are able to suck, and you can sometimes see that on ultrasound. And they're kicking. So hopefully mom has felt baby move at this time. Maternal changes. The fundus is at the level of the umbilicus, and that hormone relaxin is really in full force. And it almost makes you feel a little bit unstable because it's not just those round ligaments that are being hit with that relaxin. It's every tendon in the body. So it's great because it allows for an expanding uterus, but it's also a little bit you have to be careful. Nasal stuffiness. That is a problem at this time because of such the high amounts of estrogen present. It makes your mucous membranes overactive, and you can have some pretty significant nasal congestion. Leg cramps are also an issue. That's why we advise them to drink a lot of water. Stretching is good. For the nasal stuffiness, you have to be careful because obviously they can't take normal cold medicines. You can take Sudafed without the D. There's a Sudafed D and then a Sudafed non-D. They can't have the D. That's something that they can do. They can do a neti pot. They can do saline spray. You can use Vicks. But unfortunately, you can't take a lot while you're pregnant to relieve that nasal stuffiness. Varicose veins, due to the decreased blood return from the lower half of the body, because that baby's the growing uterus is putting pressure on the inferior vena cava. Constipation is a problem because there's decreased peristalsis. So again, lots of water, lots of walking is going to fix a lot of issues. Mom's psychological response in the second trimester is they kind of have a better acceptance of the pregnancy because they can see that it's real. Okay, so they are starting to have a bigger belly. They're starting to feel that baby kick. It shifts over to the fetus being the primary focus as opposed to the mom being the primary focus. And we have some narcissism and introversion going on. And it is a preoccupation with themselves, but it's for the benefit of the baby. So they are worried about their own health and their eating right and buying clothing that is maternity clothing. They have a loss of interest in their job because their new job is being a mom. So, they do have a preoccupation with themselves, but it's really related to, doing everything that they can to make that baby as healthy as it can be. This is where sometimes body image issues come into play, and there is a correlation between pregnancy and increases or kind of like flare-ups of past problems with eating disorders, anorexia and bulimia. So as their body changes involuntarily, that they can't really do much about it, sometimes they can develop those more mental health issue type problems. Changes in sexuality, so they're feeling a lot better during this period of time, and usually they have an increased sex drive during the second trimester. They aren't pregnant enough to be super uncomfortable, but so they're not really opposed to the idea. So now 28 weeks, we are in our third trimester. This fetus is beginning to breathe, swallow, and able to regulate its own temperature. It is also a good landmark for surfactant production. So surfactant is starting to be produced at this point in time. So 28 weeks is a big landmark to hit. If we have somebody who's at risk for delivering preterm, we want to get them to that 28 weeks. So at least there's some surfactant being produced at that time. Better outcomes associated with babies beyond 28 weeks. They're able to hear in utero, so you can start talking to your belly a little bit more. Maternal changes, the fundus is halfway between the umbilicus and the xiphoid process, so we're about 3/4 of the way there. Striae gravidarum, so that is stretch marks. It's just a fancy word for stretch marks. Will start to appear as much as people try to prevent them. There are creams and cocoa butter and all sorts of stuff you can try to prevent them. It really doesn't have a whole lot to do with how much you treat your belly. It really has to do with how much collagen is present in your skin, and some people just have way worse stretch marks than others. And the good news is they don't go away. They fade and become less red. They're very red to begin with when they first occur, because it's technically tearing and ripping of those collagen fibers in your skin. But they do fade and they kind of become like a skin color, as opposed to bright red, and they are just with you, and they're your mark of motherhood, that your mother will have to be able to hold over your head for the rest of your life. If yours does, that's what mine does. Diastasis recti starts to kind of be a problem around this point in time, so we can have that separation of those abdominal muscles. Heartburn, so progesterone decreases the tone of the esophageal sphincter, so on the rise, your progesterone will cause heartburn. So sadly, it's not because your baby has a lot of hair, but also, that baby is becoming higher in the abdomen is putting actual pressure on the stomach and pushing acids up in to the esophagus. So not a good time, probably the worst heartburn of your life that you will feel. And then hemorrhoids can also be a problem. So just like varicose veins in the lower half of their legs, you can basically a hemorrhoid is a varicose vein in the rectum, and it can also be caused from straining from stool, trying to put to stool to have a bowel movement. So hemorrhoids can be very, very painful in pregnancy, and afterwards they do tend to tone down, so that is a good thing. 32 weeks, the fetus, that brown fat is beginning to develop. There's a storage of iron and calcium and phosphorus beginning to build up. In terms of the maternal changes, the fundus is at the xiphoid process, so you're pretty pregnant at this point. Breasts are full and can tend to be a little bit tender. Urinary frequency is a problem, not due to the hormones anymore, but due to the weight of the uterus on the bladder. That baby can be kicking that bladder and causing trouble. Swelling in their lower half of their legs. They can have difficulty sleeping because it's becoming more difficult to become comfortable at night. And then a little bit of shortness of breath is usually normal, just because that baby is also pushing up on their diaphragm, which is pushing up on their lungs. So they have difficulty sometimes breathing. 36 to 40 weeks, fetal activity tends to decrease a little bit just because they're running out of room. We still look for 10 movements an hour, but we do notice that babies tend to move a little bit less towards the end. Maternal antibodies are transferred to the fetus, IgG, and brain development is key during this time. So a 36-week brain versus a 40-week brain. If you go to, it's put on by Marcia Dimes, and it's a campaign to go the full 40. It gives you 40 reasons to go the full 40, and number one being that brain is fully developed at 40 weeks, not to mention lung development is much better at that point in time as well. So maternal changes, they might start to feel lightening, where that baby drops down into the pelvis. They can have that burst of energy, nesting. A backache is pretty common, but also a backache is one of the signs and symptoms of labor. So we would, want to know if that was really coming and going, kind of like a contraction. Urinary frequency. Again, that baby's getting huge and putting pressure on the bladder. And then Braxton Hicks contractions intensify at this point because we are closer and that uterus is just practicing. Psychological responses in the third trimester of mom, there's an increased feeling of vulnerability. They start to become worried about the fact that this thing is ginormous and it does have to come out of them at some point in time. And I think it really, one of the biggest things about being vulnerable as well, and it kind of goes into this increasing dependence thing as well, is, you're not as spry when you're pregnant. So I always felt like you're kind of trapped in your body until it's over. You can't run. You feel a little unsteady on your feet, a little bit clumsy. Your center of balance is really off. I just remember thinking, like, if anybody ever, like, attacked me, I couldn't get away. And I know that sounds like crazy, and that's probably going to sound funny when you guys listen to this as I'm talking to a computer screen. But it really was kind of a feeling like, oh, I'm really, like, in a vulnerable position right now. I can't function as I normally do just because I'm huge. There's an increasing dependence. Pregnant women may be more needy during this period of time. They want their support person close by. And they have a difficulty kind of concentrating as well, just because there's so much, coming in their life, not just the whole labor thing, but it's an actual human and it's a child to care for. So sometimes it's hard to concentrate on other things. Preparation for birth, again, they're going to have that burst of energy. So they'll do some nesting, gathering infant clothing and supplies, cleaning the house, just getting everything ready for baby. And this really doesn't fit anywhere else in this PowerPoint, so I stuck it here. But multi-fetal pregnancy, we do have to talk a little bit about. We don't get too heavy into it, but knowing the difference between the different types of twins that are out there, there's monozygotic or dizygotic. So monozygotic twins are from a single ovum and sperm that later divide. And this occurs randomly. There's no genetic predisposition to monozygotic twins. And these kids will be identical. Because they came from the same ovum and sperm. So their genetic material was split in half and 2 babies were made. And they are going to obviously then be the same gender. As opposed to dizygotic twins, this is where 2 ovum and are released from an egg. Oh, I just said that wrong. Sorry. 2 ovum are released from the ovary and then fertilized by 2 different sperms. So they're not identical. They can be the same gender or different genders. They don't share genetic material other than that of siblings. Okay. So what a sibling would be, as opposed to, it's not like a duplicate of the same kid. And there is a hereditary component to this, because some women are prone to ovulating more than once in the same cycle. So they can pop out 2 eggs during one cycle to be ready to be fertilized. Dizygotic twins would also be those twins that were done by artificial insemination, where they took 2 different eggs and fertilized them by 2 different sperms and then implanted them. There's various methods for, fertility, but the gist of it is you're usually taking eggs and you're fertilizing them and implanting them, or you're placing 2 eggs and then having them fertilized in a more natural way. But those would all be examples of dizygotic. And those, so obviously the fertility treatments would not be a hereditary form of a dizygotic twin. But what we talk about in our class in terms of dizygotic is that the mom has released 2 eggs and that are to be fertilized by 2 different sperm. So here's just a picture of that. So A on the top left-hand corner are the monozygotics, where you have one zygote, it splits, and you have 2 different babies, obviously. The worry with monozygotic twins is, at what point do they separate? So these are the types of twins that you can end up with, like conjoined twins. And in these in this image, they can develop into, depending on at what point they split, at what time they separate, they can share a placenta, they can share an amniotic sac, or they can have their own placenta and have their own amniotic sacs. It's best if they at least have their own amniotic sac. It's the best if they have their own amniotic sac and their own placentas, because there can be kind of the twin-to-twin transfusion where if they're transfusing through one placenta, one baby can get more blood and actually take blood from the other blood. More blood from the other twin, and that one twin can suffer and not grow as well. If they share the same amniotic sac, then there is greater risk for entanglement in the cord with two baby cords in there and present. So higher risk pregnancy with a monozygotic that doesn't separate well in the beginning, and obviously a very high risk pregnancy if you've got some sort of conjoined situation there, obviously very rare. And then B, over on the right hand side of the computer, right lower, those are the dizygotic twins, where you've got two ovum that are fertilized by two different eggs, and they grow separately. They have their own placenta, they have their own sacs. Those are usually a better outcome. When we talk about multifetal pregnancy, it's important to remember that everything is exaggerated. So there's an increased workload on the heart. Respiratory difficulties increase because those babies are bigger and taking up more room. Maternal physiological change is greater with multiple fetuses. They have higher levels of HCG. They can have higher levels of MSAFP. Everything is exaggerated just because there's two babies in there. Key is to a safe multifetal pregnancy is early diagnosis. So knowing that there are two babies in there from the beginning and diagnosing what type of twin are they. Special antepartum classes are available to twins, not so much in our area, but bigger cities there's a class for everything. They require more frequent visits and ultrasounds just for closer monitoring. Teach them the signs of preterm labor, because a twin pregnancy in general is a risk for a preterm labor. And then nutrition is also a problem. Not a problem, but they need added nutrition and closer watching in terms of their nutritional status. Okay, so a little bit about maternal role transition and family adaptation during pregnancy. Moms, when we talk about mom, the focus is, maternal role transition occurs throughout pregnancy, and it occurs at various rates for each person. Mom becomes more aware of herself and the changes occurring in her life. And usually they seek mentors and support, talk to other moms, talk to other women, talk to their own mom for guidance. So some of the steps, in order to achieve some of the steps in maternal role taking, which we're going to cover in the next slides, these are some things that moms potentially do. Again, some of this is a little funny, but it is, they are words that you should know to be able to answer questions like NCLEX questions. So mimicry is observation and copying of maternal behaviors. That can be either consciously or subconsciously that you're kind of doing that. Role play, kind of thinking about how you might be a mom. Fantasy is dreaming of what your infant will look like and how being a parent will be. So that's, again, with that fantasy baby that we kind of have to adapt to afterwards, like this is what it really is and this is what my real baby looks like. But during pregnancy, there's a lot of fantasizing about what your life will be and what your baby will be. Searching for a role fit. So along with mimicry, kind of observing what a good mother is and seeing what pieces of being a mother you want to adopt into your plan for parenting. So we start to think about those things when we're pregnant. And then grief work is a loss of certain aspects of your current life. So especially those primates, they start to kind of realize that their life is really about to change. Their relationship with their significant other is about to change. Their relationship with their career is about to change. Having a baby obviously impacts all of that. And they sometimes feel a little bit sad. And they're happy that they're having a baby, but there is a level of sadness that they experience for their own childhood, their own adolescence, their own freedom, their own feeling of being young, kind of a thing. So these are the maternal tasks of pregnancy, and these steps are taken individually. So it takes different people, different time frames to work through these, and as long as they get through them by the end, that's fine. So there's not really a rule book as to how many weeks gestation you have to be to work through these maternal tasks, but as long as you get to them by the end, then you're usually in good shape psychologically to care for your baby. So seeking safe passage is usually in that beginning first trimester, where you are seeking the care of a physician or a nurse midwife, and you then have not really accepted the pregnancy, but you're at least following the recommendations about their diet, a good diet, vitamins, rest, and also attending those subsequent visits for care. I wouldn't say that you have necessarily accepted the pregnancy in this seeking safe passage task. After that initial step, they then move to securing acceptance. So this is where it's not so much just acceptance themselves, but it's also telling their family, telling their partner. This is where they tend to have kind of an increased closeness with their mom. They want to learn what they did during their pregnancies, and talking about pregnancy helps them to kind of cope with what they're going through. So securing acceptance is the next task. You guys do need to know these and be able to kind of pick out what, if you're given an example of a mom in a scenario, what task of pregnancy are they in at that time? The next one is learning to give of herself. So at this point, you are, you've accepted the pregnancy, you've announced it, and you kind of give your body over to it. You're kind of proud of the fact that you're pregnant and you're sustaining another life within you, and you derive pleasure from giving. So this usually is that second trimester where the focus is on you, but it's on you related to the baby. Committing yourself to the unknown child, that's a typo, that should be yourself to the unknown child, is like the ultimate, which is attachment. So sometimes these ties often start with pregnancy, and this can even be difficult. Achieving this last part can be hard, even till after the baby is born. It can be delayed and even until the pregnancy is considered viable and then beyond. So histories of miscarriage can cause moms to be less, not accepting, but more cautious about their pregnancy. So sometimes that can be an issue in terms of delaying moving through some of these maternal tasks of pregnancy. Adolescence is also an area where these tasks may be delayed, and learning to give of herself. Adolescents really aren't in the business of, caring for others. And I'm not saying that's not I'm not saying that at all. I've seen some teen moms do better than people who are very well established. So I'm not trying to stereotype or anything, but sometimes they do have difficulty moving through. I just think of teen mom on TV, and I think of, are they ready to give up themselves in order to, to fully take care of another human. So there can be delays in working through these tests of pregnancy related to different issues like those. Paternal adaptation, so it varies from individual to individual, just like it will for maternal adaptation, but it's a process that is hard for dads, I think, because the reality of the pregnancy and the child are, it's not as real, I have to say, for dads, because it's not living within them, it's not kicking them. So sometimes I think it's really hard for them to adjust. And then it's kind of like a slap in the face when it's out in the world crying at you. So you got to give dads some credit and let them, really try and get them involved. A lot of times I feel like they're trying so hard. They really want to prove themselves as a parent now that, okay, it's here and I can do more than just support my wife. I can actually support the baby. And obviously, the role of an involved father, we're providing information. Most dads really want to be present and want to help out with their child. So we really encourage that and empower them and give them just as much support as we do the moms. So some of the hardest adaptations that take place are those of grandparents. Most of the time, grandparents are very excited about a new person, especially if it is a first baby, a first grandbaby. But it does depend a little bit on age. So if you have an adolescent who is pregnant and now you have a grandmother who isn't quite ready to be a grandmother, then it could be a little bit more of an adjustment, obviously. And then those that are, have been waiting forever to be a grandparent are usually very easily move into that role. It also depends on the number and spacing of other grandchildren. So if this is, number 7 or 8, they're like, okay, another one's coming, as opposed to if it's that first one, they're camped out in the waiting room when mom's being induced for 3 days. So that really does make a difference. Perceptions of their role, that is becoming more and more difficult because people are not living where they grew up anymore. People are spread out all over the country, and it might be difficult, in terms of when can my parents come see the baby. It can cause conflicts between parents if parents don't want their parents as involved as maybe the grandparents want to be. I've had mothers crying in the hallway because the mom has said, I just want it to be me and my husband. My recommendation is always to have that conversation before you get to the hospital so we don't have a big scene. It's best if everybody knows where they're going to be prior to delivery. And it's really important that we are there and support the mother. She is our patient. So even if it's just listening and letting them voice their concerns and their feelings regarding any of these situations, we have to be on team mom, not team grandparent. Adaptation of siblings. So if you've got other kiddos running around, it really depends on what age they are. So toddlers are typically unaware that a new brother or sister is going to be born, and they are very much unaware that, it's very cute and they like it initially, but it's coming home with you, and now, there's 2 of you, and it's splitting attention from mom and dad. So that can be a little bit of an adaptation. Older children from 3 to 12-year-olds may realize the baby is going to be born, but it's really important, especially with the younger, actually all ages, it doesn't matter. They need to be reassured that, their spot isn't being taken. They're still important members of the family, even though there might be a lot of doting on the new baby. And you might see a little bit of regression as well. So you might see, a previously potty trained 4-year-old or or 3-year-old that is now having some difficulties with wanting to be the baby again. So they may want to wear diapers, they might want to breastfeed, all of those kinds of things they see as, attention seeking kind of behaviors because they want to be the baby again. It's important that parents identify a support person that needs to be able to manage their older children. We do color sometimes at the desk with people, with little people while their moms have babies, which is kind of a more fun aspect of my job. But it is better if they have somebody to watch the child so that they're not sitting with strangers to the kids. Adolescents, again, depends on their developmental level. Obviously, they're well aware that a baby is coming and what a baby is. Usually, they're just more petrified by the fact that their parents are still having sex. So that is part of it, but usually they get over it quickly and it's a good experience. So adaptation of siblings is greatly dependent on what age the child is when they get a new sibling. So pregnancy education is a very important aspect of this presentation. I really recommend that you study all of this pretty well. I'm big on education, and I think it's really important. So this is a bunch of just kind of random education thrown in here, just related to pregnancy in general. So avoiding hot tubs, saunas, and steam rooms. We don't want to cook the baby. Increasing mom's temp is going to increase the baby's temp. Travel is acceptable up to 36 weeks, as long as they're stopping every 2 hours for breaks. We want to make sure that they are wearing their seat belt, lap belt below the belly. And the reason why they have to stop every 2 hours, primarily prevention of DVTs. And then the risk for traveling after 36 weeks is that you would deliver outside of where your physicians are located. So if that is a risk that they're willing to take, I wouldn't recommend it, but that's why. Intercourse is safe throughout pregnancy unless it is contraindicated. So if you have a placenta previa, an incompetent cervix, or have risk factors for preterm labor, you want to avoid intercourse because any stimulation could cause difficulties and cause any irritation to the cervix will potentially kick you into labor. No smoking, alcohol, or drug use in pregnancy, and no douching whatsoever. Pregnancy nutrition, we want to tell them to increase their caloric intake by 300 calories a day, which is not very much, considering what you're doing, growing a human. But I think we probably all consume a little more than 300 calories a day when we're pregnant. Normal weight gain. So these are the normal weight gain numbers for each category of weight. So if you're underweight when you become pregnant, you are allowed to gain 28 to 40 pounds. If you're of normal weight, you're able to gain 25 to 30 pounds. So that's the one you should remember. And then 15 to 25 pounds for women who are overweight, and then 11 to 20 pounds for people who are obese. So obviously the more you weighed prior to pregnancy, the less weight that you can gain during. They actually sometimes are glad to see women who were overweight prior to pregnancy lose some weight during their pregnancy, and that is actually okay as long as the baby's growth rate is appropriate. Increase their level of protein, iron, and folic acid just for fetal health. Drink a total of 8 to 10 glasses of water per day. That's not only good for hydration, prevention of preterm labor, and also heart health as well. Limit caffeine to 8 ounces per day. So 1 cup of coffee is completely fine, or 1 caffeinated beverage is okay. Food precautions. So we want to avoid large fish due to the level of mercury that is present. Shark, swordfish, and mackerel. So if those are on your dinner plates on a daily basis, you want to avoid those. Limit tuna to 6 ounces per week. We Tuna does have some mercury in it. It doesn't have a lot of mercury in it. And we limit it to 6 ounces per week because there are some benefits to eating tuna, especially for eye health and eye development of the fetus. No raw or undercooked meats or poultry, so no over easy eggs, no rare meats. Everything should be cooked well done. Wash raw veggies very well. There's a risk for toxoplasmosis. We talked about that in our high risk disorders section. No soft cheeses. Brie, feta, gorgonzola are examples where bacteria growth can be present and it can be transmitted to the fetus. Nothing unpasteurized. So unpasteurized honey, vinegar with the mother in it. So there's that big trend where people are drinking apple cider vinegar to for weight loss and kind of GI tract health. We can't do that when we're pregnant. Be careful with lunch meats. So I say be careful because it was always like avoid lunch meats altogether. You can have lunch meats if you heat them up. I know that sounds gross, like who wants deli ham heated? But I guess if you're desperate, that's what you would do. It would decrease or remove the bacteria, which is listeriosis, which actually is responsible a lot of times for fetal death. So if that is transmitted, it caused maybe some GI upset, nausea, vomiting in an adult, but in a fetus, it would actually cause death. So lunch meats, I just think it's safer to avoid them altogether. The other thing you want to avoid is things that are high in nitrates. So lunch meats would be one of them. Hot dogs are another. A lot of nitrates you want to kind of stay away from. Bacon. Again, I mentioned this before, but nutritional risk factors, eating disorders in terms of anorexia and bulimia sometimes become more apparent during pregnancy. Women will also develop food cravings and aversions. I'm sure you've all heard that, I wanted this so much when I was pregnant, or I couldn't even look at that when I was pregnant. There's also an increase of pica of pregnancy. So that's more than just food cravings and aversions. Pica is actually more of a psychological disorder that can develop where you're craving foods that you're missing in your diet. So ice is often craved in women who are anemic in pregnancy. Clay, dirt, soaps, chalk, toothpaste, ashes, and it's kind of like an uncontrollable urge to eat these. So sometimes people who are low in iron will eat dirt or clay to bulk up on that. It's kind of it's more of a psychological disorder than an issue with pregnancy. And then we need to also worry about how we teach adolescents when it comes to nutrition. So those pregnant teens, think about how a teenager eats. Not so hot these days, a lot of fast food, a lot of junk. So it's not only, it's hard to get them to eat well for themselves, let alone their baby. So in addition to that, who brings the food into the house? Typically their parent. So, and some may not have access to a car or have a driver's license to be able to get healthy foods. So we just have to make sure that whenever we're teaching an adolescent, whether it be about nutrition or anything, really, you want to teach them on their level. And you don't really want to teach at them. You want to, treat, and I guess it's really about how you treat all patients in pregnancy in terms of teaching them, talk to them on their level. They have to be a part of the conversation, and you really have to kind of develop a relationship with them before they're going to accept any of the education that you're providing. So really, make sure, especially with adolescents, that you're trying to develop that rapport with them so that they take your recommendations seriously and will, do the best that they can for their pregnancy. Nutrition in the lactating mom. So the first 6 months, After delivery, while you're breastfeeding, you can increase your calorie intake by 330 calories. In the second 6 months, you can increase your calorie intake by 400 calories just to support that growing fetus. Increase in proteins and fats, because that's what the highest content is in breast milk. Nutrition in a non-lactating mom, they can return to their pre-pregnancy diet. It's unaffected. It doesn't, there's no reason to maintain a certain diet. Weight loss occurs usually 7 to 10 pounds in the first week, and the greatest loss is in the first 3 months for those moms who are non-lactating. Usually women who are breastfeeding will lose weight very quickly because of all the energy that they're burning off from supporting the human. They also, things to avoid, while breastfeeding: alcohol. There's rules around alcohol. You can drink, but you either need to pump and dump or wait at least an hour after drinking, per glass of alcohol, per serving of alcohol, to breastfeed your baby. Exercise in pregnancy, regular exercise is recommended, but not more than what you previously exercised prior to pregnancy. So if you weren't, somebody who exercised a lot prior to pregnancy, they don't recommend that you go out and, take one of those HIIT classes or something like that. Or, you can gradually increase your exercise as you become comfortable, but do not, increase to a level that you aren't prepared for, just because you're pregnant. Avoid activities in which the abdomen could suffer from trauma. So no skiing, water skiing, or contact sports. Walking, swimming, jogging, and yoga are all acceptable. Yoga may have some modified positioning to account for the fetus. So usually a prenatal yoga is recommended, but all safe methods of exercise and pregnancy. If you're a runner prior to being pregnant, then you can certainly run while you're pregnant. Different types of classes that are available to moms who are pregnant. So we have, and it really just depends what the content of the class is, depends on what, point in your pregnancy you're in. So if it's preconception, the focus is going to be on nutrition and a healthy lifestyle, signs of pregnancy, choosing who your caregiver is going to be, effective pregnancy on relationships and career, education in the first trimester focuses on adapting to pregnancy and what to expect. Education in the second trimester is related to if they're high risk, they might need extra instruction. But usually in our area, the first, second, and third trimesters are all lumped in together. And it's kind of nice because it provides for a variety of experiences that get to be shared. And usually towards the end, we talk more, in the third trimester, we talk more about coping with fears and being in that vulnerable state. So it really depends on the mix within the class. There's childbirth prep classes, which focus on coping techniques, relaxation, breathing, conditioning, labor partner support, how to manage labor. And then breastfeeding, has its own separate class in our area where it's, a class specific to how to breastfeed your baby. Classes for other family members, they are present. We have sibling classes around here, and we also have a class that's called Dads on Duty for fathers, and it's just for men. So that's kind of a nice environment for guys to attend and kind of talk freely among other guys. Grandparents, there are classes for grandparents, not really locally to us, but they exist. And then there is a separate class for parenting and infant care that moms and dads can attend. And I will say there is a postpartum class, but we usually roll our postpartum classes into the childbirth prep and do kind of like a final segment on postpartum care in the childbirth preparation class. So all different configurations of these across the country, and how they are carried out just depends on where you live and what access you have.